Hey, good afternoon, committee members, technical advisors, and other parties of interest. This is the Evaluation Committee Consultants Analysis Meeting for request for proposal 24-24912 for the self-funded group health plan for the Human Resources Department. And it's being held via the Communications Media Technology. Provisions have been made for members of the public desiring to have access to view the meeting. Public attendees must remain on mute and cameras off. For the record, this meeting is being recorded and the recording will be available after the meeting has ended. Please be advised that the cone of silence is still in effect and shall end either the earlier of 5 business days after the county posts a notice of intent to award or the date of a procurement solicitation cancellation. All questions, comments, concerns must be directed to my attention. As a matter of housekeeping, technical advisors that are here with BKS for consulting are going to be presenting. All other advisors and observers in attendance via the communications media technology shall remain on mute unless speaking, and keep your cameras off as well. If you have called in, please do not put your call on hold. My name is Sakina Ford and I'm the chief buyer on the project. For the record again, this meeting is being recorded. And I will hand this off to Scott Stromer, our director of procurement, for some important guidelines.
Okay, just to remind everyone, the previous presentations this morning were exempt under Florida law for those meetings, and they were recorded and will be shared after the fact. This meeting is a public meeting and has been noticed as such, so the public can listen and sit in on this and online, whatever. So it's even more crucial now that just to remind everyone here, including the consultant, that information was shared by the 3 parties. They had very broad exemptions, claims of trade secret. Again, rather than litigate that, we've just made the choice of let's just temper those. The committee members have all of that information in your proposals. You can refer to that. You can couch it and kind of mask it in such a way that nobody's details are shared openly. So if there's a reasonable person sitting here, they wouldn't have any idea what you're talking about, other than when you boil that down into what does that mean for the county and for this committee to help make that decision. It's a very, very important decision. Obviously, you guys spent a lot of time on this, and HR staff. So again, I just reiterate that this committee has the time you need to make this decision. You have a meeting scheduled tomorrow, and we have another backup date if we need to. So don't feel like you have to make a decision, on a schedule. We're going to get you there. Today is for the consultant to really kind of go through and give you their take on everything and give you the details you need, kind of help navigate some of these complex topics, because you guys have regular jobs. This is not something that everyone's highly trained in. I'm certainly not. So with that, all yours.
Let's go ahead and make sure we introduce again on the way around. Committee members first.
Cheryl Murphy, Human Resource Manager for Hillsborough County Wellness.
Mike Gergo, Senior HR Partner for Total Rewards.
Donna Stark, Senior Functional Business Analyst, Enterprise Solutions and Quality Assurance.
Tim Pearson, President, Hillsborough Firefighters.
Colette Duffield, Project Manager with Hillsborough County Healthcare Services Department.
Tom Bessler, Chief Financial Administrator.
Irma Muka, Budget Managing Director with the Management and Budget Department.
Jamie Logue, Senior Client Manager with the Baldwin Group.
Jean Kelly, Client Executive Leader with the Baldwin Group.
Tony Bethke, Managing Director, the Baldwin Group.
Rebecca Burley, Benefits and Retirement Manager, Human Resources Department.
Paul Almeida, Contracts Manager, Hillsborough County.
Ernie Mayer, Senior Assistant County Attorney, Labor and Employment.
Christy Olosino, Procurement Operations.
And online, we do have some of our technical advisors if they are called upon. So if our technical advisors online would please introduce themselves.
Ivy Martin, Human Resources Director.
Maria Liddy, Human Resources Division Director.
Cindy Shuko,
Neil
HR Fiscal Manager. Neil Gemma, Executive Board Member, Hillsborough County Firefighters.
Thank you. So we will go ahead and hand it off to Baldwin Group and let them present.
Okay, well, thank you guys. So I think we have about 3 hours together. I want to start with maybe just reframing a little bit our role within this very complicated. I know you guys have seen the proposals and had a chance to look at how thorough, one, the questions that were asked of the responders, and then how thorough the responders' responses are. It's quite a bit of information, and we know that a lot of it is a broad, to Scott's point, a broad spectrum of it is exempt from public disclosure. So our task today really is to try to disseminate that information in bite-sized chunks to make it like a little bit more digestible, but in a compliant fashion, so that we're honoring the proprietary information the carriers have, suggested is proprietary. So what you are going to see from us is 3 parts. We're going to start with this morning. We wrote down some notes, and we took down, I think, so we wrote down and took some notes on opportunities where we might just be able to provide you guys some clarity or some context around some of the Q&A. Again, honoring any of the public disclosure. Or honoring any of the information that is exempt from public disclosure. So we thought we would start with just kind of some talking points from earlier today, maybe have a little bit of Q&A with you we're going to offer some clarifications on some things. We're going to give you a chance to maybe ask some additional questions. And then we'll flip it over to our presentation. As Scott mentioned, our presentation is subject to a little bit more scrutiny as far as what is shareable in the market because of the public disclosure exemptions. So what we've tried to do, again, is analyze kind of a side-by-side comparison of some very in-depth, complex and financial information, but break it down into some highlights that really are a visual for you to look at in each one of these buckets that we think are important. And let me rephrase that we know are important, because we spent about 1.5 years prior to this with your HR team identifying what matters most to the counties from a financial perspective. So we're going to break that down into we're going to keep it super simple, red, yellow, green, right? And meaning comparing these 3 responses to one another from a financial or a, kind of goals and objectives perspective for the county, which one is the stand out from red, yellow, green from a comparison perspective. And then we're going to identify for you where we think you need to go into the actual proposals to look at the detailed financial information that we can't share in a public setting. I don't think any one of these buckets, I think we'd all agree that not one of these single buckets every one of them need to be looked at as a whole to determine what makes the most sense, right? So that's really why we tried to color code it, because what matters to one individual committee member or even to the plan is as important as all of the information as a whole. Does that make sense? Anything else that you want to add to that, or? Okay. So this is going to be the very interactive, because this was hot off the press this morning Q&A. So if there's an awkward pause, just know that I'm trying to read my information and be mindful of talking about it without, violating any public disclosure exemptions. So I'm going to start just kind of in order of who presented to us earlier today. United Healthcare started us off this morning. And one of the questions from the committee members was regarding the network disruption. And I think it's important to point out, so I think the question was along the lines of there is a small percentage maybe that was not in network from a provider network perspective. I think the responders answered appropriately in that anybody who says to you that there's going to be 100% overlap just isn't true. And what we talk about today literally could change tomorrow, because provider contracts are, they're coming in and out of the network all the time. What I do think is super important to keep in mind is that all 3 of the responders have very comparable networks. There are no gotchas or outliers here from a network hospital provider perspective, right? So looking at some of the responses, some of the network access information in the responses, which is a geo access or a provider disruption report, you're going to see that the overlap is anywhere from 97 to 99%. And the other thing that I think is important to pull out is when you look at the top 25 providers, so looking at the actual providers that the county has used, the top 25, they're in network with all three of these responders. So I think that's important to keep in mind. The United Healthcare called out which area where they thought the disruption was. Those were not any of the top 25 providers. All of the hospitals are in each one of these provider or carriers responders networks. Moving on to.
May I ask a follow-up on
Yes.
that? Awesome. Let me figure out how to phrase this. I guess the concern was about that question is that general providers are easy, I use quotes, to find, right? It's the specialty and their response was concerning to me because that is a very specialized niche. And I'm thinking specifically for our first responders. How much of a disruption is that going to make? I mean, we already hear concerns from our first responders that it is difficult for them to find those types of services. And I just want to bring that. Does that make sense? Does my question make sense?
It does, but let me zoom out for a second because the word specialty provider could mean so many things. It really means anything other than a primary care general practitioner, right?
Didn't they say drug rehab or something like that? Or
Yeah. So when we use the term in the industry specialty provider, that could mean an oncologist. That could mean doctor. Podiatrist, thank you.
Anything that ends in IST.
Yeah, there you go. I love it. Anything that's IST. So I think the response that and perhaps where you're going with your question and where they touched on it, when you say specialty provider, I think what I'm hearing is more behavioral health.
Yeah, thank you. Yes.
Okay. Okay.
That was a better substance abuse.
So I would say that their answer was fair and just, and it would be the area of focus where any change in a network might experience the most disruption. Now, arguably, that's a very small percent of the overall network. Sure. However, that can be a very personalized relationship, right? So you're going to hear the potential for noise if there's not 100% overlap there, certainly is a possibility. And I think that brings me back to, I think what I wanted to touch on in the opening that I probably didn't, is everything that we weigh out here and everything that you guys are going to be tasked with voting on is going to be a very delicate balance between what it costs and what the cost of doing that is, meaning how are your employees going to be impacted? And that is a balance that is going to literally be different on a line by line basis. And kind of one of the most difficult tasks that you have is balancing what is our cost and what is the opportunity cost with that? Because there's going to be disruption with any decision you make, because change equals disruption. Change also equals opportunity. So I think that's a fair way to put it.
Thank you for letting me ask that.
Yes, absolutely. Any other question on that topic before we move on? Okay. The next thing I think I want to point out and just observation, we talked about, I think one of the questions from the committee was low-hanging fruit from a pharmacy perspective. And again, very fair and just response. One thing I do want to keep, or one thing that we think is important to point out is as far as generic dispensing rates, all of the responders had an opportunity to make a proposed pharmacy financial, all of them gave us a financial proposal. The response is I encourage you to go back and look at what your generic dispensing rate is today, because that is relevant. And there are some performance guarantees within some of these responses based off of how many drugs are being filled on a generic basis. So that's important to keep in mind too. Go ahead. Oh, okay. I think that there was also the next piece of kind of low hanging fruit was an opportunity to discuss the GLP-1s. I want to just make sure when we're zooming out and we're looking at how do these responses compare to what you have today, you do not cover, the county today does not cover GLP-1s for weight loss. So if you have utilization today within your pharmacy program for GLP-1s, that is a diabetes diagnosis. That is the only way that drug could be covered. So there are always opportunities with any vendor, with any pharmacy benefit management program, there are opportunities to save. You are already doing that from a generic dispensing rate and from a, what are GLP-1s covered for today? Yeah. So I think one of the questions that came up in each one of the responder Q&As was biosimilars and the opportunity to keep or steer to biosimilars. Hands down, we don't need any financial piece of information or any data to say out loud that a biosimilar is going to be less expensive than the brand name drug. And any opportunity we have to steer people to a less expensive drug is an easy win for the county, right? It's an obvious win. One thing to keep in mind when you are steering away from a brand name medication, you are impacting the rebates within the plan, right? So this is 100, all of the proposers have to a certain extent, and we'll get into the details of that later, a version of a 100% pass-through or a rebate guarantee. The county today is already participating financially in rebates within your pharmacy benefit program. We're not saying don't steer away from biosimilars. We're saying that any change or navigation away from a brand name drug today could impact the rebate that you're eligible for. And that needs to be evaluated when we're looking at overall cost. It's not just the lesser cost of a medication, it's what are we losing in rebates? And does that equal similarly? And if it doesn't, that's okay. We just need to think about that when you're looking at your plan design and any changes to the plan design. We talked about adverse reactions, or there was a question about adverse reactions and opportunities to steer around when there is an adverse reaction within step therapy. I think everybody had a similar answer as far as what you can do from a step therapy perspective. I just want to remind everybody, you guys currently have step therapy in place. And so while every one of the responders are going to have, contractually speaking, different levers you can pull from a step therapy or different drugs that are prioritized on their formulary as requiring step therapy, there's a similar process in place today to require step therapy before you move on to a higher cost, typically medication. And there are always kind of exemptions to the rule if there is a medical reason for that. Questions on anything that United Healthcare talked about this morning? Yes, yeah. Yep, we have it. Yeah.
It seems like longer ago than this morning, right?
Yeah, I know. It's like yesterday. We had a lot of information.
Ages ago.
Yeah, yes. Okay. So with that, then, if there are no questions, I think we'll jump over to the Aetna commentary. Give me just a second to get down to. Let me back up. I actually have an additional comment on the United Healthcare. So one of the comments with United Healthcare with the proposers' responses, and this is similar to the second round of proposers. So I want to encourage everybody to go back and look at the Q&A analysis within the proposers, the questionnaires, excuse me. So within each of the proposers' responses, there was a questionnaire and everyone was specifically asked to answer a question about whether or not there were any opportunities to deviate from a prior authorization process. And that was a question that was asked of all of the proposers. The information shared today differs from what was included in the responses. So we need to talk about that, or you guys just need to reevaluate that. Next question.
Can I jump in for a second and can I ask procurement a question about that? So what they put in the sealed proposal is different than what they said today. So we have to basically, the thought process is what they put in their sealed proposal is what the answer is.
That's the primary thing that you should evaluate is what they're in writing, what they offered you, right? So you did a solicitation, invited offers, they gave you an offer. That's what you're doing. Understanding that way you have a baseline for everybody. Understanding that at some point there's going to be negotiations, ceteris paribus, right? So everybody that's even there. So that is, now the committee can consider different information just in the quality of their response. So they can consider that, but start with the proposal, and you should not, if it's more favorable to the county, what was here is presented today, I would caution you for grabbing onto that.
And I think that's a really fair way to say, I'm not suggesting what was said today was wrong. I'm saying it differs from what the written documentation is. So I think that's important to note out or point out. Another one along, so we talked about the prior authorization. We also, some of the responses that we received in the questionnaires was specific. And I think one of the questions that was asked in the Aetna Q&A session was whether or not narrow networks were allowed. So within the questionnaire that we received, the response today differed slightly from what was included in the written response. And I just think that's important to point out.
Can I just say this?
Yeah.
So those two items, when the committee sits down and deliberate, when you start looking at that, you can remind them of those two areas.
Yep.
So when they're scoring, when they're going through that, you can remind them that, okay, just that there was a difference.
Yes, and I think that when we get into part two of this kind of our analysis, I think we'll be able to point out some areas in the Q&A. So absolutely. So the Aetna response is, well, when we went to pharmacy rebating, and so I think one of the committee's questions was regarding 100% pass through and whether or not there was a rebate. So the response that we received today did align with the response in the questionnaire. I just want to, I think, kind of expand on that a little bit. What Aetna is proposing is a fixed rebate, fixed flat fee within the program, and that is shored up on an annual basis. So they suggested to us that it is 100% pass through. So basically what they pay, the county pays, but that is not shored up on a quarterly basis, right? Like it is shored up on an annual basis and then passed back to the county. That is different than your current rebate position today, which is paid out on a quarterly basis. So that's dollars back to the county on a more immediate basis within the current program today. One is not better than the other. One is not right or wrong. One is a different cash flow. So with that, go ahead.
So no difference in, like, you wouldn't get more money back if it's on quarterly or annually. There's no scientific proof that that would be the case, correct?
Yeah, based on the response, you are receiving all of the money owed to you, just at a different payment rate.
We get it annually now.
Okay. So let me rephrase that, Mike. I'm sorry. I think the other proposers are suggesting a quarterly payout. So it's different than the other responses. Sorry about that. Questions on the Aetna, which I know that's a very blanket statement.
Have you started? No, I'm just kidding. Sorry.
Okay. Anything else? Okay. So I think I want to touch on skipping over to what we just listened to with Cigna. So maybe there'll be more questions. It's probably the most top of mind. I want to touch on a couple of the Q&A information. Specifically, let's first jump over to capitated fees. So this is going to be a very broad conversation. We're in a public setting, and the specific financials are exempt from public disclosure. When we get into our presentation and our analysis, you will see where we've highlighted for you where to go to find that information. What I do want to speak to is the questions where how do the capitated PEPM rates being proposed by Cigna compared to the capitated rates that you're paying today in the incumbent program? They are similar. And we know that because we checked the county's average on a plan year basis for all of the 2023 plan year. And then all of 2024, January through August. And the proposed fees align with, on a per member per year basis, what the county is paying today. So there is no significant difference in capitation. Now, what Cigna did say is your capitated rates are subject to trend, just like a claim dollar would be, right? So when you're comparing that to the other proposers who absolutely said we do not capitate any services, those are all paid through our plan on a per claim basis. we know that all medical costs, right, are subject to inflation and trend, right? So we would expect a claim to increase based off trend. Cigna said we would expect capitation to increase based off trend as well.
Can I just repeat that back in the words I heard in my head?
Okay.
So, and thank you for that, because that was a big question I had. The proposed amount is very similar to what we're already paying. We're not going to see a multi-million-dollar increase in what we pay because of what that number we're seeing in that capitated fee.
Correct. And I will show you where that number is in the proposal, the response in the proposal. And if someone in your financial department wanted to compare that to what you're paying today, you would look at a Cigna claim report and identify where your capitated fees were. Compare the two.
But cross comparing the Cigna to the other two.
Great question. So we are gonna go into that. I'll talk about it now. We are limited somewhat in our ability to share financially what that looks like for you. One, because the Aetna and United Healthcare could not give you necessarily a projection on that because it's not currently a claim, right? What we can tell you as your consultant is we have access to claims data in our book of business for all of our clients. And when we compare removing Cigna, when we look at our book of business, right, and our health intelligence platform, and we take Cigna out and we look at everything else, there is a per member per year, and this is a rough estimate, right? We compared, and the claim dollar per member per year is actually a little bit higher than what your capitated rate would be, but that's to be expected, right? Because there are less, not everybody's having a claim for those instances, right? So I think to answer that in a way that honors the public disclosure, arguably, if you looked at a per member per year claim basis, it should be a little higher than a capitated fee because not everybody's incurring that claim. Does that answer as best as?
It's kind of knowing that capitated is to save a little bit of money.
Yeah, so you're basically spreading the risk. You know, go ahead, Nicole, sorry.
No, I was just going to say, because we are going to dive into that a little bit more when we get to those comparisons. So.
And I think it's huge disclaimers. It's really hard to compare the two, but and the closest we can do is say, what's the average capitated per member per year? What would be an average claim per member per year? And the per member per year claim is a little bit higher.
A quick question on the capitation. When you mentioned it was subject to trend, is there a maximum cap that it can trend in a given year?
Oh, okay. So now we're really getting ahead to our presentation. So. So, well, just got my color code out. So yes, so their trend is, and there's a lot of different ways that trend can be defined in the market, and carriers have proprietary trend numbers. What the responders had an opportunity to do was make some guarantees on some of that information. And I will tell you, when you look at the three responses, Cigna and United Healthcare offered you a choice of a network discount guarantee or a trend guarantee. Aetna's response only included a network discount guarantee. Again, we are not saying one is better than the other. The responses differed in that fashion. Thank you. Yes. Other questions? Oh, okay, Becky. Let it go. All right.
Becky's hurrying us
Yeah,
along.
Becky said, get it together, Dave. Okay, so now what I'm going to refer you to, and I'll be looking down a lot, is the presentation that Nicole passed out. And you're going to, as we go through, really, we're going to spend a lot of time on the next 2 pages, which are the color-coded red, green, and yellow. And it really is, as much as possible, a condensed level of this entire RFP response. And when I say as much as possible, we spent about a year and a half building out the questionnaires. Like, there's no way for us, it would take weeks and weeks probably to evaluate every single one of those responses, right? So what we tried to do is identify, where do we know the committee is going to be asked to score? Where has the county identified that was the most valuable to you, whether that's a financial value or a employee engagement value? And we've kind of bucketed those and compared the 3 to one another on a line-by-line basis. We then kind of went into all the questionnaires and said, all right, where do these responses really differ from one another? And we really tried to highlight for you where the responses differ so that you can go back and evaluate that. So a lot of what we're going to talk about in this executive summary, we have left out the financial details. But what we're saying is, like, for example, if you're looking at the ASO fees, first thing we've done is define for you where you can find the details on that information within the proposals. Sometimes there's more than one place, which makes it a little difficult. So we tried to list all of them if they were there. But what we broke down for you is and let me just clarify for anybody who doesn't realize, and I'll apologize, in our industry, we love to use acronyms a lot. ASO is the administrative services only. Basically, it's the flat fee, the fixed cost agreement that you're going to enter into for the responders to administer your plan and pay your claims, and administer your pharmacy. So each of the responders broke down their responses, and we have highlighted annual fixed costs, like what are your annual fixed fees? And you can see that there's a green, red, and a yellow. And so go ahead.
I'm so sorry. My vision, I cannot see any of the highlighted things.
Can I share it onto the?
No, we cannot share.
Right. I knew that.
So you may have to read it. Is what I'm saying.
Well, so I can't read much other than, so that first there are 3 bullets there.
Okay.
And the first bullet is just fixed cost, right?
Okay.
So what's the flat fixed cost? And
Cool.
and what we tried to do is line up each one of these proposers on a side-by-side basis. So Cigna, Aetna, and UHC, and you can compare that first bullet in each one. And yeah, oh, thank you. And we've identified green, yellow, and red. So on just a fixed cost fee, go ahead.
Is everything exactly the same on all three?
Yep.
Okay.
Yep.
Awesome.
Yes,
And I'll
they're
be
the
able to
same
follow
color.
through.
Look at the color.
Yes, yeah.
You'll see that Cigna is a little like more condensed, but yeah, they're all the
My apologies.
exact same order. And we know.
No, I tried to print this as big as I could, Cheryl.
It's okay. It's the color on it.
Yeah.
It makes the words just disappear for me. So
Yeah.
it's all right. As long as I know what those are then.
Yeah, so very first one is annual fixed costs.
Thank
Okay,
you.
Green. The next bullet is what is the rate guarantee? So how long are they guaranteeing that cost to stay the same? And we've identified, again, you can go across the board and compare each one of the responders from a green, yellow, red perspective. And then if you want to go back and see the details, we can tell you, so keeping in line with public disclosure and things that are exempt from public disclosure, I'm not going to state for you the specific amount of time, but the best response does have a 2-year longer rate guarantee than any of the others. The percentage of rate cap. So the second bullet is saying, okay, how long is that fixed cost going to stay the same? The third bullet is saying, okay, when it is subject to increase, what are the proposed rate caps, or what's the maximum rate cap? So you can see again, green, red, yellow, as far as what are the maximum fees. And we're talking about a couple percentage points different. Now, here's the part that I think is really important to also call out is what is included in that fee, right? So again, I encourage you to go back into the proposals and look at the information, because every one of them have a very detailed ASO summary breakdown. But the Aetna and United Healthcare response, to a certain extent, there are pieces of the clinic that are included within that fixed cost amount. Whereas the Cigna response is including that in some of the financial funds that are listed in a different section. So what we're trying to say is, again, we're not suggesting one is right or wrong. We're suggesting where they might differ. So credits, financial resources. What we did there is break down on an annual basis, what is the commitment? So if you look at the first, just comparing the first bullet, green, yellow, red, we're saying how much are they going to give you annually? And referring back to this morning's conversations, there was a lot of discussion about on-site reps. There was a lot of discussion about wellness initiatives, wellness resources, clinic initiatives, clinic resources. It's how much money are each one of the responders willing to provide to the county. In addition to doing business with you and paying those fixed costs, what are they willing to give you to fund some of these things that are not currently a line item in the county's budget? They're built into your health plan costs. So there's an annual commitment from each of the responders. There are one-time or fixed commitments, right? So if you look at the Aetna and the UHC, the Aetna, they're saying here are some one-time going into it upfront, one-time only commitments. Cigna is offering you some commitments on a life of the contract basis in addition to those annual. United Healthcare has built everything into their annual upfront commitment. So there aren't any additional buckets outside of that upfront. Now, we have bucketed all annual commitments. So if you go into each one of the proposals, you're going to see that there's an allotment for funding on-site reps versus wellness or things like that. The annual commitment is specific to certain line items within you have to look at the proposal to look at that. What we've done is said, what's the total annual commitment? What are the total one-time charge commitments? And how do they compare to each other? Everybody offered, so I think one of the key factors in scoring is the premium, the kind of concierge service model. So what the high service touch that is so critical to the county and to your employees. I use the word negligible, can't use the word negligible in that they are the same or equal. So everybody across the board offered you some sort of premium concierge service. Now, we'll get into, again, we're going to go over, and this is probably where we'll spend a lot of time with the committee, but we're going to talk about some of the differences in the response. All of them have a service that is an elevated or advanced escalated customer service resource or portal for your employees. The one difference is not everybody has a 24-hour hotline, where 2 of the 3 responders do have a 24-hour hotline. Moving on to now, we're going to talk about some of the things that are built into paying your medical claims, right? So where everybody, all of the responders are for a fixed cost going to pay claims and process claims, pay claims on your behalf because it is a self-funded plan. They're also going to administer your pharmacy benefits. What we've done is break down those 2 buckets by medical and pharmacy. And the very first bullet is looking at what the responders were all asked to do is look at an existing claims file and reprice those claims using their network and their network discounts. I'm going to use the word negligible again, and in the sense that they were all within a couple percentage points of each other. There's no less than that. Thank you. So what you would have to do is go back into the 0.6. Yeah. Well, that was
less than 1.
Network discount.
Oh, yeah.
So I think it's less than 1% on the claims repricing, or right around 1. Yeah. When we're getting to performance guarantee, it was less than, yeah. Does everybody understand what we're saying there as far as the medical claims repricing? Okay. The capitated, so are there capitated claims or not? We compared the 3 responses. 2 of the responses do not capitate. It's just passed through as a claim. 1 of the responders, Cigna, your incumbent, does capitate. Behavioral health and imaging.
And Embark.
And Embark, yes, thank you. And that is a program that is unique to your current plan. It is like they talked about, I really liked, it's to protect against the lightning strike, right? It removes from, and let me go back to, I think this is a really important question. I'm glad you brought that up. So the Embark program, when we go back to Cigna's responses, it is insurance for high cost pharmacy claims. You pay a fixed fee for that. And I think there was a question about, because the Embark program, we know that any surplus and fees paid are paid back to the client. And I think it's important to differentiate client and member. And the reason it's paid to the client is because the client is paying that fee. Members, when they have a claim incurred that qualifies for the Embark protection, they're not paying anything out of pocket outside of what's required by the IRS for a high deductible health plan. So it wouldn't be paid back to the member because the member's not incurring that fee.
I have a question on capitated fees. Aren't we currently paying for capitated fees for lab work?
Imaging and behavioral health.
Imaging and x-rays.
Yeah.
So not for cost and lab core? Okay. Thank you.
And behavioral health.
Yeah. And there is a schedule. So if you go into, to answer your question earlier, and I said I'll point out where. So if you go into the folder that says specific to the responder who has capitation, if you go into the file or the piece of the response that says exempt from public disclosure, and there's about 150 pages in there. In there is a schedule of what's capitated.
It's 280.
Okay, 280. Who's counting? Yeah.
Which comes from the response of the ASO.
Yes.
That's what I think you were referring to.
I'm sorry, say that again?
What she's talking about in that document that is exempt from public record, it goes into more detail about that question you asked Cigna about the one capitated fee.
Mhm.
In the ASO, it's only identified that way. In that disclosure, it's identified deeper.
Oh, okay. Thank you.
Okay, so we talked a little bit about like network discount guarantee. So that is where, again, it's less than, there is a difference between each one of the responders, their response, but it is less than a percentage point difference. And I think it's important to point out there are fees at risk. Any one of these carrier partners are going to work really hard to achieve those network discount goals for you. So you're probably not going to benefit from that fee at risk. I mean, it's a great protection, right? If we don't hit these discounts, then we're absolutely going to put some fees at risk. But ideally, we don't want that payout because we want to achieve the network discounts, right?
Can I ask a question on that?
Yes.
So you said the network discount guarantees are all kind of within a percentage point of each other. So can I ask why one of those is red and?
Yeah.
Because
The guarantee amount.
Yeah, so the guaranteed amount, so how much fees are at risk, and there is a financial dollar assigned to the fees at risk,
Okay.
and that's where the red, yellow, green came
Okay,
from.
gotcha.
Yep.
Which we can't disclose.
Yes.
Right. No, but I was like, it was like, it was kind of
That's a great
one of
question.
those negligible ones, sort of, and I was
Then
like,
why
wait a
are they
minute.
all green?
Exactly, right?
And so that's an excellent point, and I'm going to point out to you one error that we identified, and I'm going to take 100% responsibility for it, hot off the press. So the very bottom bullet, which also is a discussion of discount and guarantees and fees at risk. The yellow for Cigna is correct.
Okay.
The green and red for Aetna and UHC should be reversed. Yeah.
Okay.
And what we're saying is who is going to put the most fees at risk if those savings aren't achieved? And it should be UHC as green, Aetna as red.
Recovery too, a percentage of recovery.
Percentage of recovery, yeah.
return to the county.
Yes, let's return. And we were going red, yellow, green based off of what the carrier gets, not what the county gets. That's not what we're.
Oh, right.
Okay, so the one thing that I want to talk about too is from a red, yellow, green perspective. One of the things that's been super important to the county from an innovation perspective over the last couple of years, we've talked a lot with your team and where your HR team wants to. It's really important, right, to be a top employer of choice and to have competitive plan designs. And what competitive means to your employees is constantly evolving. And some of the things that we've talked about from a cost and quality perspective that are of high value or potential future value are something that we call narrow networks, right? So can we say within the network that you offer within a carrier, can we exclude maybe some providers that aren't meeting certain benchmarks for whatever reason from a cost and quality perspective? And if we do that, does that drive some more value and lower cost to the county and or to our members? So we highlighted who is able to do a narrow network and who is not. One of the things that we've also talked about a lot is plan design innovation. And everybody, so we heard this morning from United Healthcare about one of their programs. One of the things that I think they touched on it, or they spoke to the program really well, but it is a co-pay driven plan using their broadest network of providers, but it's tech enabled. So what that means is when they talked about the left turn versus the right turn, can we use a technology to steer people to the most valuable provider? It doesn't always mean the cheapest provider. It means the most valuable provider, right? So who have they identified is identifying certain benchmarks within cost and quality analysis. They have a tech-enabled program that they've included in their proposal that would give employees a scheduled copay based off of where within the network they went. The other two responders absolutely have copay-driven programs, and you could absolutely build a copay plan design for your employees. Copay meaning no deductible, just a fixed dollar amount when they went to the physician for any specific service. The difference with Cigna and Aetna is they did not include any sort of, they don't have that tech-enabled program. So that's just the difference in the responses.
So that would be a completely new plan design.
Yes.
Okay.
Yes. And anybody can offer you a new plan design. It's the differentiator in their response was, here's a plan design that is driven by a technology to drive you to the provider that's going to provide the best outcome and ideal. And we're going to reward the employee with a lower price point for doing so. Excellent point. Oh, yes, did I hit a bullet? Did I miss the?
We just want to cover the pre-authorization and again, because that's listed here as part of this.
Okay, so one of the questions in our questionnaire, so I would encourage everybody to go back and review the ASO questionnaire. That was the Q&A response in the responders' responses. And whether or not there's an ability to, the county today currently decides which services they would like to require a pre-authorization. For the good of the group, a pre-authorization is a cost containment measure, right? We don't want people just showing up willy-nilly to get an MRI because they had a headache that day. I'm oversimplifying that, but that's just an example. Yeah, there is a, right. Let me just show up. I think that my appendix hurts. I don't. And believe it or not, people would do these things. So I think it's important to keep in mind the value of pre-authorization is it's a cost containment measure for your program. There's not anything wrong with having prior authorizations. However, the county's question was, do we have the ability to decide where we want to apply those restrictions? And the responses in the questionnaires do differ from some of the information you heard today. So you just need to review that. Thank you. So now we're going to move on to the pharmacy claims, right? So everybody is administering pharmacy claims through their wholly owned, pharmacy benefit manager. The one outlier with the ASO, so when you go back to those ASO fees, you do see at the bottom, there's an asterisk regarding United Healthcare. There is a per script admin fee that is different from the other responses. So that was included when we evaluated red, yellow, green on the first page and those ASO fees. We accounted for that as a fixed cost in your ASO fees because it would be on a per employee per month basis, which is similar to how your ASO fees are defined. Cigna's proposal is including a flat rebate per script with a shore up at the end of the year. Now, this morning, they did tell us that that is 100% pass through. So you're receiving all of the dollars back, but on an annual basis, where as United Healthcare and Cigna both proposed 100% quarterly rebate, 100% pass through with a quarterly rebate payout.
I think their Cigna's executive summary said 100% pass through on it.
Yes. Yeah. Okay. Yes. And then the rest of what I've done there, Cheryl, so like the bullets, the remaining bullets are really, and I think one of our responders, I don't remember which one, but they would all tell you this if they could, trying to evaluate a pharmacy contract is a very difficult thing to do. Like it is a very, very detailed process. So what we tried to do is, one, we built a questionnaire that each of the proposers had to respond to, and it was a pharmacy pricing analysis. So if you go back into all of the responses, there is a 1 year and a 3 year breakdown of total costs and what we think what they are saying the county would incur using their network and their claims. Now, I do want you to, and here's the difficult thing, and we'll show you, but it's a very redacted piece of information. But we did a side-by-side comparison, and each of the responders, and there are valid reasons for this, but I need you to realize that they're reviewing a different number of claims. So you are going to see a different number of claims, a different number of employee count, a different number of member count from each of the responders. And so you're going to see a different total estimated liability. There are a lot of reasons for that. They all cover different drugs on their formulary or just outliers within the data that they were given. So what we tried to do was take that very complex analysis and highlight for you red, yellow, green as best as we could without disclosing any information. So some of the things that we looked through was whether or not it was a pass-through, whether or not, or we compared ingredient costs, dispensing fees, vaccine admin fees, per script admin fees, and whether or not there was a limitation on quantity or grandfathering for newly issued medications. Grandfathering for newly issued medications is, let's say that and I'm just going to go back to Humira for a second, just because we talked about it for a second. Like, let's say that we all of a sudden want to require step therapy for the biosimilar, right? And there's a lot of other drugs that aren't specialty drugs that this could be the case for, but we require you to use this certain drug first. There's an opportunity for you to build within your plan design a grandfathering clause where, all right, Gene, for the first 3 months, and maybe insulin's a better example, but Gene, for the first 3 months, you can go get that specific insulin pill, but you've got 90 days to figure it out and get on the one that our formulary covers, right? So the question to the responders was, will you allow us to do a grandfather? So it's kind of the carrot versus the stick into getting them into the right drug and allowing people the opportunity, or are you just going to deny it and say it's not covered right off the bat? And the responders had a different response to that. Again, we're not saying one is right or wrong. One is different than, or, if you're doing it one way today, that is different than some of the responders proposed. So again, red, yellows, greens, those bullets, Cheryl, are equal. If you go across the board, if you're kind of scanning Cigna, Aetna, and UHC, it's whether or not it's passed through, whether or not it's what the ingredient, the dispensing, the vaccine, and the per script, and whether or not they'll allow grandfathering. And we compared each proposer's response to one another in a red, yellow, green perspective. On-site resources. I urge you to go back again to the sections in the responses. The services not a part of the ASO all had kind of a detailed breakdown of what was included, what applied to those financial resources. I want to say that this is a little bit difficult to respond to. I feel like today, nobody deviated from what they proposed necessarily. They clarified it, and I just think that you need to go back into the responses. But everybody is proposing, to a certain extent, on-site rep within the clinic, on-site service rep. Some of those are going to be employees of those organizations, or they're going to be outsourced. And you're funding those reps in different ways, right? Some of it is included potentially in an ASO fee. Some of it is included in some of your annual financial resources. So you're going to have to compare the two. Question.
Side question, kind of related. Out of the 5,500 employees, how many are we seeing per month at the clinic?
Last month, there was 88 visits last month, but it is trending upward, which is very good. And I will say that Evernorth said to us that they use us as an example in that the implementation of the EMC has seen just really good exponential increases in utilization to the point that it's better than any other program they've implemented. So I took that as a huge compliment. So I'm interested to see this month and November what the utilization was, because we're pushing physicals for January 1st rebate. So,
and let me just add, they
increasing
filled
quite a bit.
up every single physical appointment that was available for the rest of the year.
I see the value just out of the 5,500 employees. I don't know how many are in this general area, so location's important.
Right. So obviously, we're piloting this program and taking baby steps. There's definitely room for and definitely a desire to expand. First, maybe to other locations, and then also to spouses, dependent children, perhaps even say pre-employment physicals and drug testing and that kind of thing. But right now, we're just looking to see how does this first location do, and we put it here specifically because there are about half of our participants are in this building. But it is definitely a desire to expand that, in maybe the next contract, starting in January 2026, really expand that. I would say probably the first location that we would expand to would be somewhere around the Falkenberg 60 area, because again, we have hundreds of employees that are saturated in that area. But we also see a need for North Tampa, Northwest Tampa, as well as way South County.
And just for the sake of the record, Becky, how long has that facility been open, the medical center?
February, about the third week of January was the kickoff.
Okay, and the very last piece of the executive summary were performance guarantees. So that's different than network discount guarantees. It is, what are the things that we are committing to? How are we going to do our job? How quickly are we going to pay claims? How quickly are we going to get ID cards out to your employees? How quickly are we going to answer the phone and resolve customer service issues? And there's a whole schedule that each of the carriers are proposing. And then there's fees at risk for not meeting those specific benchmarks. And then we highlighted just red, yellow, green from potential, competitiveness for overall fees at risk.
I have a question. I'm so sorry. I hope you're not jumping ahead.
No.
For the last bullet on the one on the far right, should that say actually medications not allowed? Right here under pharmacy?
Or UHC, for the
I
grandfathering?
think that because it's red, I'm thinking it should say not allowed.
Yeah, because Aetna says medication's not allowed.
Yes, that is correct. Yeah, not allowed. Apologies, not allowed.
This one?
Yeah. That is correct. So not allowed for UHD. Cheryl, you can't read it. Could you see my struggle? I'm so sorry. Okay, so the next couple of pages of your presentation are heavily redacted. And I apologize.
Can we just make a note though, but we did our best to redact this. There might still be some things that shouldn't be disclosed.
Yeah, so we're not going to say them out loud, but we wanted you to know, like, that, to Scott's point in the beginning, like, is this a really lengthy, RFP, and you guys are looking at a lot of information. There was a really in-depth analysis, behind the scenes that we really tried to, we did compare line by line, like a lot of different information, but we had to bucket that into like a digestible amount of information and in a shareable format based off of the public disclosure exemptions that we had to work around. So the next couple pages really are breaking down administration, provider discounts, medical claims repricing, the employee medical center, and then spending accounts. So something that is important in a part of this evaluation that we didn't spend a lot of time talking about, but any of these carriers that have proposed to you or have provided a response would also be someone that we would be looking at for your flexible spending account and your health savings accounts for your employees. I'm not going to spend a lot of time on those pages just because we can't. So what I would like to jump into then, I think the next is, I got a little out of performance guarantees. So what we did then, also redacted, but what we did is try to schedule out for you where you can see where they've put a specific dollar amount or fees at risk for each of those performance metrics. The pharmacy RX pricing and fee summary, again, that is heavily redacted, but you can see that we took each of the responders 1 year and 3 year analysis and compared them to each other. And then if you go back to the executive summary, you can see kind of where, again, like we took the key metrics here: ingredient costs, dispensing fees, vaccine costs, total allowable administrative fees per script, and we highlighted those in red, yellow, or green for you. And then again, bless you, in the executive summary, scared me.
Trying to hold that one in.
In the executive summary, we've highlighted for you where you could find the details of that information. Is the provider network access?
Network access, yeah.
Okay, I got out of whack here because.
Okay, this is the redacted version.
Okay, can I borrow it?
Yep.
Okay, so the network access, then what we've done is taken out details percentage details, but we did do a bar graph for you on a side-by-side analysis of each of the networks from a total provider, percent of employees without access. You can kind of, it's pretty self-explanatory, but like, I do want to point out that we think there may be an error on Aetna's report for freestanding labs. It shows, you know, hundreds of thousands more in the area than everybody else. And their network is vast and broad and very good, but I don't think there's that many more. There's an outlier somewhere that's not, in, you know, there's so many reasons why that could go wrong when you're running an access report. That's by no means a reflection on the accuracy of the rest of their data. I just think we have to point it out. Same thing from a national pharmacy network perspective. Everybody is very similar as far as the number of pharmacists, retail pharmacies on a national basis. Maybe anything that I missed on any of the network stuff?
Great summary.
Okay. Okay. The next part is really at the, I think at the committee's discretion. What we've done then is, and again, we tried to, as much as anywhere possible, there's a disclaimer there that we tried to redact anything that we believe was exempt from public disclosure. But there were a large number of questionnaires. So a question and response document that each of the proposers had to fill out. And what we've done for you is try to highlight areas where we think there are differences in their responses. And so if we jump into, I think it's page 19 of your presentation, when we get into claims administration. So this is, again, some of the questions are, you know, how quickly, oh, am I not in the same?
No,
Is that not right?
well, there should be 18 first that we didn't go over.
Oh. Well, there's no differences there.
Oh, gotcha.
Sorry.
No.
So, but thank you for calling it out. So I skipped 18, was just a really nice summary of the type of plans they administer, what they can do for you. This is all the same. There are no differences. Sorry, Jenny, that's why it's confusing, but I just thought this was important to highlight. What are the things they're saying they're going to do for you? And everybody can do similar service, you know, provide similar services. Where it's different is where you see red, and that is different from current, each other, and current. So percent of claims auto adjudicated, that's like how quickly, or the percent of claims that they're processing without any sort of manual intervention. Again, I'm not sure that there's a right or wrong. There's a benchmark that the county is looking for, and the responders had an opportunity to you know, provide their answers.
And that's one thing to throw out there quickly. The red isn't indicating a lesser benefit like we did in the red, yellow, green comparison. To Jean's point, it's just different than current.
And I thought, you know, if it's something that like I said, we spent probably about 1.5 years with your HR team working very diligently to build a very thorough question bank that made sure it honored, you know, matching your current program. So if the HR team and you know, you're in conjunction with us felt like it was important enough to ask, we thought we should call out where it was differed from each other. Provider network. So again, here, this is, if we go to page 20, do you offer a narrow network of providers? You can see, you know, one of the differences there. I will caveat, let me jump ahead to provider network. So United Healthcare's response was, no, they don't own 100% of the network. They own 99% of it. And where they don't own the network, it's typically overseas. So I don't want that to, you know, scare you. I just think we're calling it out as different, but it's not a huge difference. Are all hospital-based physician services affiliated with network hospital contracts? So what that is there's kind of an ongoing open issue within just our industry as a whole, where your employee may be going to an in-network facility for services. And the average consumer would just assume that if I'm going to an in-network, if I'm walking in this building and you're telling me it's in-network, everything I do here is covered in network. That's actually not the case. There are providers that work in that facility, but don't necessarily work for that facility, and they may be out of network. So the question the county asked was, do you make sure everybody in this building is in network, yes or no? And everybody had a little bit, you know, different response to that. There are reasons for, again, not better or worse, just different. I'm sure that every one of the responders would tell you they would love to require everybody that walks into that building to be covered in network. There are reasons why sometimes that's prohibited. Will your organization provide the county with the ability to remove a provider or facility from the network? So in network, right, we're not talking about a narrow network. We're just talking about a network and we just are seeing egregious charges or what we, the county has just, and, you know, kind of through our due diligence, see as egregious compared to maybe another provider in the area. Can we eliminate them from the network? Or we've had a high level of concerns or issues. I will tell you that all of the carriers have a very thorough due diligence and credentialing to require, you know, that require, they ask providers to meet in order to be in the network. But if for whatever reason, the county wanted to be able to remove a provider, either from a cost or a quality perspective, the response is different as far as whether or not you can do that. Whether or not they administer the funding account. So it's talking about whether or not the FSA or the HSA is administered. So this is really not something that, like, all of them are proposing a service. It's whether or not they fully own that service or if they're outsourcing it. Same thing with COBRA. I'm going to skip through that. I think where we're going to want to spend a lot of time is, so the employee medical center, do you provide an on-site medical center that is fully staff funded and independently operated by your organization? So Aetna's response, you saw that their partner clinic was here with them. They partner with someone. So they're not saying they don't do a clinic. They're just saying it's not wholly owned by Aetna. Are there any, so now we're getting into implementation and open enrollment. So this is significant each year. I'm sure you've all had to go through your open enrollment process and make your benefit elections. This is kind of behind the scenes, some of the services that your HR team are going to need to administer the plan successfully.
The Employee
Yes.
Medical Center. Saying fully staff funded and independently operated, weren't some of those fees coming out of the funds that provided?
Yes.
The answer is technically no then.
I would agree that it's not fully, they're providing resources, but you're either paying for it in some instances, you're paying for it in an ASO fee. In other instances, you're paying for it in some of those financial resources. The other thing that you need to think about too is whether or not, and I would encourage you to go back into each one of the responses, because that's just to operate the clinic, right? And then it's, okay, when an employee goes to use the clinic, how are we paying for that? Because there is a fee for it, right? Is it a fixed cost or is it a claim charge? Or is it a fixed cost that's friendly claim charge? And those are all things that need to be evaluated. Audits. So one of the things, for those of you that aren't aware, there are performance guarantees within your plan that all of the carriers are saying, hey, we're going to guarantee an accuracy rate for our claims processing of this amount. But as we all know that, you know, there are errors within claims that are inappropriately denied or inaccurately denied. There are performance metrics or fees at risk that each one of the carriers are putting on the table. But what the county asked was, will you allow us to hire a third-party independent firm to come in and evaluate that ourselves? So great, you're telling us about your accuracy rate. Will you allow us to bring on site to your facility or have access to your claims so that we can independently audit that? And the responses are different there. Some of the compliance questions are specific to different types of fees and assessments that are imposed on the plan under the Affordable Care Act, healthcare reform. Gosh, not HIPAA. Let's see, the price transparency. There's all kinds of government legislation, federal government legislation that your plan is subject to, and it's whether or not they are going to provide you some resources or the information that you need to file those, assess those fees accordingly. The concierge service, so whether or not it's 24 hours, I think that's the biggest differentiator there is 2 of the 3 have a 24-hour. Dedicated customer service line for your employees, yes and no.
Back to the 24-hour. I have a question. I wish I would have asked it in the presentation. Darn it. Did you see anything in the proposal that, or the answer, one of the proposers stated that there's a nurse available 24/7? So isn't our question asking more about, is that customer service? So if I'm working an overnight shift and I have a question on a billing, is that nurse going to be able to answer that
No.
question?
Correct.
Exactly.
Yeah, so, yeah, and I would go back to generally speaking, not specific to any proposal response you guys have, but generally speaking, almost all of the carriers, I believe, have a nurse hotline that's available, right, 24 hours a day. That is like, hey, it's the middle of the night, my kid has a cough, I don't want to, I'm not sure if I need to go to a clinic, let me call and ask the question. That's a nurse hotline.
Right.
Hey, I got balanced bills and I, work all hours of the day, so I'm calling you at night. That's different. Or, hey, I have tomorrow a doctor's appointment or imaging and I don't have the prior authorization I need or whatever, I need your help. That's 24-hour customer service versus 24-hour nurse hotline.
And the question was asked about customer service.
Correct.
So then that answer should really be no for that particular.
I'd have to go back and look at the responses. I know there is one who is saying, no, we don't have a 24-hour customer service hotline. The other two were saying yes, but I don't know if they broke that down in the comment. Let's read it. It's not in that comment, yeah.
No, we'd have to.
Well, it does say something about the nurse. It includes,
It's 2.0.3.
yeah, 2.3. So is there a defined turnaround time for responding to after hour calls? So those are like actually two different bullets. So the first one, Cheryl, is just yes or no. And then 2.03 is there a defined turnaround time for responding to after hour calls? Yes, with caveats. Yes, with caveats.
There was something else in there. Okay, well, never mind.
In the responses, there might be a more detailed in the proposals.
Yeah.
International pharmacy program. So I think that, Mike, you touched on this, I think in all of your, and I think this is maybe what you were talking about, or like programs. I think you mentioned the cost plus. So all of the carriers and their wholly owned pharmacy benefit managers have similar type cost savings programs. But certainly we're seeing a trend in the market where employers are looking to outsource that to a cost plus or, the Mark Cuban type thing. Another alternative that we see growing in popularity is international pharmacy programs. And so the question that we asked the responders was whether or not they would allow, because some pharmacy benefit managers have very strong opinions about whether or not they will allow you to have that program stacked on top of theirs. The other thing that is not part of this response and not part of, but like, I think there's a couple things you need to think about here is, will they allow it? But bigger than that, and this is a different RFP scoring, like your stop loss. That's important too. Would it be covered by stop loss? So that's not for the purpose of here, but this is not, I guess what I'm trying to say is this is not the only place we need to ask that question when you're evaluating responses.
Before we move beyond the ASO questionnaire, can I ask a question? As I was reading through online their proposals, I noticed several of them would say, yes, that this is included, but you utilize the credits or help funding money that we're giving you. And when you say that for all these different things, as a reviewer, you get to the point with, well, how much does that amount that you're giving us cover? So I would have appreciated this item costs this amount, and yes, it can be included in this fund or whatever. But now I'm kind of at the point where, does it cover all of this that you're proposing if we want these things or whatever between the different vendors?
Maybe an a la carte menu with a limited budget.
Yes, exactly. But we don't know what
What's
each
the value
item
of each?
cost. Exactly. We don't know the value of each item. So it's very difficult to make an adequate comparison.
Yeah, I agree. I agree. And all of them are making very generous financial offers that I will tell you that so we are consultants for both public sector and private sector employers. And I will tell you that one of the values that, some of the public sector clients public sector clients benefit from are additional resources for, it's very common to have a wellness fund. It's very common even for a very large employer to maybe have an on-site funding a clinic, funding marketing, funding, mobile clinics or things like that are not something that the carriers typically put dollars towards. So they all have a very generous offer on the table. However, you're right that in places where they're allotting those dollars to fund some of the bells and whistles the county's getting, there's not necessarily a dollar value assigned to that. So I feel like, that's my response.
So, if I could just interject here and ask a question of BKS, because this all came as quite a shock to me about all of this redacting. Never seen that before. So I just would like to ask the Baldwin Group, have you seen this with your public sector clients, RFPs recently? Or?
I can say recently, this is not something we've experienced. I'm not going to say ever, but
Right, I think it's, to working with procurement and just kind of some of the language that was used in the proposals.
You mean what we asked?
No, I think what we got was just in protecting that information.
Yeah, I was just wondering if it's protecting all of your public sector clients. Do you see proposals coming in with all this information redacted and saying, trade secrets and all that kind of stuff?
So when we look at our public sector clients, we also look at them on a national basis, and Florida has very specific laws about what is public information, right? Not every state has sunshine laws, for example. So sometimes I'm answering this as delicate.
They're already protected in other
Right,
states.
but they know, like responders know, to be fair, that when they give this information, literally anyone can go out there and look it up. And are they going to understand what they're looking at? Not saying right or wrong, I'm saying that's,
No.
I think.
So on that, I want to move on from that. But second, you have all of the information in your proposals. And if you think you need to have one-on-ones with the consultants, that's something we can do. We just have to get that scheduled. Certainly can do that. But again, the committee, you have that information in your binders. This is really, and they're giving you an overview of it. So I don't want to belabor that. It is what it is.
And we tried to, in our executive summary, say, hey, look here.
Yeah, I know, but it's just not germane to the conversation.
The next couple pages are the questionnaire. Did I answer your question?
Well,
should we?
Sure.
Okay. Before I move on.
We don't know what we don't know.
Yeah.
So, okay.
The next section, oh, no, I didn't. I skipped the PBM questionnaire. So let me go back to PBM. Sorry, I was jumping ahead in my proposal.
It was just the very bottom that had we were on 26,
Oh, okay.
which is just the
Oh, okay.
bottom that was
So,
liar.
oh, that's not.
Yeah, so.
Yeah, we can move on from that. Okay, so where we are next is 5 or 6 pages on EAP and behavioral health questionnaire. So these are not, this is very hard. All of them have, from a EAP and behavioral health perspective, very similar responses, meaning you're going to have within your EAP an unlimited number of telephonic, you're going to have 6 visits. You have an opportunity to, in some form or fashion, provide some on-site behavioral health services. Everybody has a different way of funding that, or different type of maybe clinician or qualified individual to be available. But the county did have some pretty significant Q&As, and everybody gave you access to, or a response here that talked about the type of communication resources. Like, I think it would not really be a good use of our time to go through this, but it is a side-by-side, and Cheryl can't read it anyway. I feel so bad. I'm sorry, Cheryl. So this is the one area where we kind of just included everything, because there are very specific responses. I'm not going to say different. I'm going to say very specific. Overall, everybody is providing a resource for EAP. Overall, everybody's going to give you at least what you have today, which is the 6 visits, unlimited telephonic. All of them are very interested in supporting you from an on-site capacity in different ways.
Are all 3 of these 6 visits, are they all the 6 visits per issue per year?
Per issue, yes. Yep.
So
Yep. And the EAP is extended to all of
Family members.
yes. So that's different than, like, say, an on-site resource, right? Like adding an on-site resource, that would be for an employee only. And while we're continuing to evaluate what on-site means, right? Like on-site probably would be right here at the county center or the employee medical center, which may not be a viable solution for all of the county's employees. So something.
Not only that, employees don't like to come to.
Yeah, it's downtown Tampa.
Or to even, discuss their EAP issues.
Yeah.
Around coworkers.
Fair.
I have a question, maybe, and I'm jumping ahead, maybe.
I think so. I think that's it,
Yeah.
Cheryl.
Okay.
Now we're to the Q&A.
Anybody see anything in the proposal about a van?
A van?
Because that was the first time I saw it. And with Scott saying, look, you really need to go by what was written. And now we've got the van by the side of the river.
Well, I think that falls into your $2 million a la carte.
I don't know.
It seems like it include, you could, I think it was worded, you could have a van that drives around the county with county logo on it.
I thought he was gonna say it again by the river.
I said over here, I was like, I picture Cheryl driving the van.
I totally pictured myself driving the van.
I do think that you're right. I don't personally recall that seeing that as a line item, but definitely all of them talked about the additional resources and opportunities and innovations for expanding, based off the county's wishes, like expanding some of the resources. So I think we could say, hey, that probably falls into that, but yeah, I don't remember a line item for it necessarily.
And I should have asked the question of the proposer. Maybe we have follow-up, this is a really good point that he just brought up. Where's the cost of that coming from?
Yeah,
So we need to find that out.
Yeah.
That's something to be considered, I guess. Is there money left for it after we do all the other things that were guesses that we don't really know the price for?
Good point.
We're on the subject of money. What are we currently spending on capitated fees? On an annual basis?
I don't think we can disclose that in this setting, so.
Is it available to us in these?
You're saying what the county is.
Currently today, not what's being proposed, but what we currently
Yeah, I
are
don't
doing
think
today.
that's not.
Okay.
Well, I think, so it does line up. What my comment earlier was that what they're proposing aligns with what you're paying today. So I think that if we said what you were paying today, you could deduce what.
Yeah, and I don't think that shouldn't be a problem because somebody from the public that asked that information, you're going to have to give it to them because it's a public expenditure that's real, it's happening today. So.
That's true.
I mean, you can give a range if you're feeling, you can do that, but I don't think we have to be.
So I think you're spending on average today based off, so we looked at your 2023 plan year, which is all data that's been emailed back and forth. So that would be, okay. So the monthly claim reports, right? Like that's where, okay. So plan year 2023, you spent about $40 per member per year. And year to date in 24, about 44.
Per member per month or per member?
No, per member per year. I broke it down on a per member per year.
So the particular capitation, correct me if I'm wrong, my concern was the number that's listed says PMPM.
Right, but we changed it into, let me make sure that I'm saying per member per, right? Just per member per year. Hold please, I can answer, let me just confirm.
Because that would be 11
It is
times
all
what
the-
we're paying now. In my quick math. Are you looking at the redacted?
This would be total claims.
A report from.
Okay, sorry, total claims or total fixed total members. That's for
We have
the-
Bindi online. Does she know if I can? Mm-hmm. Mm-hmm.
Can we clarify that? Yeah.
Absolutely.
Misstate, that's
Yeah,
And for me, that is a big clarification.
Yeah, for sure.
Indy, do you know, since you're online, do you know what we're paying capitated fees about per month? Are you seeing it in your claims information?
No, the capitation fees amount, it kind of comes through our claims, so it kind of buried in there. But roughly like every week, I mean, I wouldn't say every week, I know the last week when it came through, we were looking at almost 500, I don't know if I could say the numbers, it's okay, about 500,000 that came through.
I would say a month, not a week, a month.
For,
Because I'm looking at a claim report.
so that came through for a week for behavioral health capitation, I guess. It came at about roughly under 500,000 for 1 week. And I'd have to go back and see if that was similar for every month.
I'm comfortable saying that there was about $5 million, a little over $5 million in capitated fees for the 2023 plan year.
Okay. And that is very similar to what is in that proposal. Okay. All right.
So perhaps I'm using per member per year, but I mean, but
Yeah.
total charge 5.8 is a more realistic number. That was, and
Yep.
that I am disclosing something that has been released via email. So
Thank you for that.
Yeah, and if we look at the 500,000 over the 12 months, it comes to roughly, yes, the 6 million. So that looks like it's in the ballpark.
okay. So then what is in, perhaps I'm using per member per year, but I stand by the numbers aligned.
Thank you. Thank you for that.
Sorry about that.
Other question, I also don't see in here, like we had a reporting and integration questionnaire. I don't see a comparison of the responses in here.
There was. Yep. Hold on.
There was
Or there, so if there were not a lot of differences, then I hit anything where the questions, we hit anything where the question and response is aligned. But let's go into the ASL questionnaire.
Because there was a couple notable differences in that questionnaire. So I was,
When we got into the PCORI fees, so we talked about PCORI fees, that was that was compliance audit. Oh, it's right there.
Yes. But I think don't get it, children. It is. Look at it. Look at how cool it is. Pulling it up, Donna.
and
Okay, so I think that those were not, let me unhide it here. Not part of the ASO questionnaire.
There was a specific reporting questionnaire.
And system integration.
yes, it's on the system integrations are what I'm specifically speaking to at the moment. And if, no, I got it.
That's where they answer regular ad hoc or both, right?
Mhm.
Yeah.
Reporting abilities. Okay, so. Bless you. So I think we left it out because the responses were similar and that, remember, this is the one, both are regular. So they're all saying that they can, for the most part, when you look at the analysis of all of them, it's basically saying, yes, we can do it. Or we can do both, like both, their responses were different, but they were very generic and they said either both or regular, which is not really saying they can't do it.
Well, I think the one that stood out to me is that there is one of the three who is unable to provide discrepancy reporting off of our eligibility fees on a weekly basis. That's very concerning to us. And when we asked for sample reports, only one of the three actually gave us sample reports for what what the discrepancy reports look like. And that, and just for the record, the reason that's of importance is every week we would send enrollment files to whoever is our selected vendors. It's critical to make sure our systems and their systems remain in line so that our employees and their dependents have access to the care that they need when they need it, or that their claims can be adjudicated correctly and so on.
So 2 of the 3 said, yes, we can do it. And then one of the 3.
One of the, yeah, and only one of the, I should say, one of the 2 only gave a sample.
That's,
Is that protected information?
no.
No, it's not invasive.
Oh, Edna responded, no, they cannot. United Healthcare and Cigna both said we can do it. I'd have to go into the sample reports to confirm. The examples of the reports may actually be protected information.
Like if they have it, and you have copies of it, you can see it, you can score based on that when you sit down to your deliberations, so.
Okay. Yes.
That's how I was looking at the form and see if it was.
It wasn't.
Yeah.
It was, yeah. Well, could have been me. It had to be sick.
Confirm, were you at a point where you still had a few more things you wanted to discuss or?
No, we're open to anything that you guys want to discuss. If there's anything specific in the EAP behavioral health that you wanted to talk about, we couldn't, our analysis or the leave behind that we have for you, and nothing is highlighted in red because they all are similar, but they're just replying in a very specific, different way than one another. So we're not going to be able to compare apples to apples, right? You just kind of have to read through those pages.
So tomorrow, they schedule to meet tomorrow, and if that'd be your first opportunity really to start to score or start to work through that logic of that criteria. So tonight, having their presentation, going back and look at the proposals, you can kind of see the information for yourself where the differences may be. Questions you may have that you can bring up and discuss openly there. You can discuss it here if you'd like. It may be better for you to kind of digest that stuff. And then tomorrow afternoon is when we're going to meet. And again, if we need to set up another time between now or between tomorrow and the 18th to do that, we have that opportunity. Once you have that discussion. So
Scott, so if we did that discussion among same rules.
Because it's eventually going to be shared with the public, so.
Makes it kind of difficult.
Tomorrow's meeting.
yeah, you can still discuss and score. You can still do all of that. But, you know.
But it's difficult to say this one said this and this one said that. You can't say what they said.
Right, exactly. So do we just have to write numbers on a notepad and show to each other that the camera can't see?
Each other, if somebody saw something that somebody else didn't see, it's just.
Well, without getting specifics, you could probably say they were popular, they were lower, they were, inferior, or whatever. Not ideal, but
no,
this is a bit of uncharted area.
Yeah.
So
Also, having everything redacted on this report makes it very difficult because now we have to go back and redo what the consultant has done, basically. Right? I mean, like in my opinion, everything that's redacted, now we have to go back and review or find out which.
you can unredact your versions of it. Right, you can pull your redactions off.
Post that on.
We can.
Consultants.
Yeah, we've got it redacted and unredacted.
Yeah.
That cannot be shared with us.
No, it can be shared.
That will be helpful to have.
Again, you
cannot be
have
shared.
the
It can't be shared
original information.
They've summarized it. To have the unredacted summary would be helpful.
I mean, yes, because they've done all the work. It will take me days to go and do that.
And that's why they're here to go through that with you. And they'll be there tomorrow, and they'll be there the next day. So, again, it's just, we'll have to get with the attorney's office. If you want that, there's some risk when you're in those sessions, because you're gonna have the redacted versions, you're still gonna talk about it. So it's, still talk about it. You don't have to get into so-and-so said this.
So tomorrow, just to restate or clarify, we will be on site tomorrow for the entirety of tomorrow's meeting. And we will have our redacted pieces to have a conversation, but we can't say out loud those.
Right, yeah, you can still have, yeah. Because here's the alternative. and this is even for those that are sitting in the audience, my alternative is we'll have to go litigate this. There's no time to do that. So I'm trying to figure out if we can do it. Now, if the committee says, listen, we just no way we can do it, and then we're gonna go right to that. We'll have to probably go to an interpleader and say, Judge, what can I share? What can I not share? So that's where we're at. So we're gonna try to do this. Is it ideal? It's gonna be it's gonna be some more work. It may be. It's going to be. It's difficult. I know it is. But ultimately, you'll have to decide if this is something you can do or you can't do.
Is there a way that we could get an idea of cost for, so we know what the capitated fees are from the one proposer and what categories that's covering? Is there a way that we could get typical, which there's no such thing, but typical claims cost for those same categories for somewhere that has the same number of employees or members?
Can I just zoom out for a second on that? Because I think it's relevant, and whether or not you want to capitate is important. But I want to just, capitation is 4% of your overall claims. It is a very small number. I don't know that you need, I thought 6% was the other carrier. 4 to 6. I would say that when you're looking at it on it, when we talked about earlier that we pulled out our book of business, we pulled Cigna out and we looked at claims on average and they were a little higher. Both of them were within 4 to 6% of total claims, right? So capitation is important from a transparency perspective. And I'm not telling you which one is better. I am telling you it is a very small percentage of your paid claims. And it's probably, there's a lot of things you probably do need to make a decision. I'm not sure if that question, because that would take more time to go back to the proposers and ask, right?
So even if you're talking about, if it's 5% of the claims, if
Yeah.
there's even a 10% difference in price and capitation, it's 0.5% of the overall.
And yet claims might be at 5% if we took those on as a fee for service. Instead of capitated, if the claims came in on an annual basis, it would be 4 to 5% of our, so it's.
But even significant price differences between them is not significant to us.
It's not.
Okay, so that's what we.
It's a good question. And
Yeah, exactly. Because it makes a huge difference, you know, cost in this column versus cost in another column. And when we don't know what those costs are, it's impossible to compare.
I think that for the purpose of the committee, the things that are going to be really important to you are total paid claims, medical and pharmacy, right? And those numbers from a medical perspective were pretty negligible. Pharmacy, there are some differences. You've got to go in and look at those pharmacy pricing and summary tables. There are some differences on a 1 year and 3 year basis, right? And then you got to look at, okay, what's our fixed cost and how long is that fixed cost guaranteed for, right? Those are the ASO fees. And then how much financial resources are we getting to fund all the things that we do today and the things we want to do in the future? And are those annual commitments or are they not annual commitments?
Based on the information that you have and the data set that you have, you can give some projections to the committee. You can say, well, based on what we have, we would project that this is, you know, it's what's the cost of the employee, what's the cost of the county, what's the network disruption. That's information you share. Is that true or not?
In global, like on a total basis?
I mean, after analyzing the proposals, giving the committee, here's what the impact of that is or what we would project.
So I think, is it possible for us, given what has been redacted or not, like, could we be here an hour early to answer some of these questions individually for some of our evaluators?
We'd have to, how long is that meeting tomorrow?
1 to 5.
Yeah, so if you're there at that time, we can set aside maybe the 2 hours or whatever if you needed to have private meetings, but.
I think we would feel more comfortable with that because we have a lot of those numbers, but I feel that given what was listed as trade secret information, we wouldn't want to offer that in the public forum.
But going back to my question though, based on, to give them, here's what we think the impact would be on the plan or what the cost of the county would be, the employee network. You can give that information based on it.
Yeah, so the overall the evaluations and the responses really aren't talking about employee costs. We would be looking at employee disruption, right? So we can evaluate that. And we can say, here's what proposer one's total cost is. If we're in a private, not a public forum, here's what proposer two's.
Yeah, but the total cost, it's not taking, I just want to make it clear. Whatever their details were, whatever those ingredients were, it's how that's balled up. Based on everything we saw and what we were presented, you're not sharing their numbers. You're saying our projection would be, this would be the cost. So I don't know that, because that's your analysis. You're taking what they gave us, that'd be your analysis.
I'm sorry, are you talking about cost of claims or cost
Yeah, because
of?
we're taking.
Whatever cost you need to get
But
this
we are
down to.
taking our analysis based on information that they've
So-
provided.
I mean, what's the difference between private meetings and passing a summary sheet out with unredacted information at the meeting to each of us? And then then it's our responsibility
Not to share.
not to share.
In fact, we could hand it back.
Specific information at the end, we hand it back.
Yes.
Well, the handing back part is, yeah, that, we'll have to talk about that. That was with the attorney's office. We see talk about that.
We can do
Yeah,
that
but
tomorrow, right?
like I say, if you can unredact what that is and bring it in and have this discussion. But in that public meeting, when you're talking about it, you just can't,
We can't.
you can, they can't to you because
no
it's
one-
recorded.
So let me just say that back just to make sure I'm understanding. We pass out a piece of paper that has unredacted information for you guys to look at.
Including the pricing information.
Right. Assessment of what that means to you. We're just not saying out loud, like you can't in a out loud conversation say, hey,
Right.
Jean, is this X dollars?
We can say one's less than the other.
Yes.
Okay.
Column A.
I was gonna say,
Well,
could the
line
information be
13.
presented and each row number?
Well, it's
So
going to be
on
exactly
row
what you have.
13, yeah,
We've got it unredacted.
Right,
Okay.
it's gonna be exactly what you have unredacted.
okay.
Yeah, there's,
I mean, that would be helpful.
Could we also get your projected totals, cost totals for each proposal?
so this is, we're not, in a self-funded plan is how you develop future costs based off of a lot of variables. What we're looking at here are line by line items. How much are your fixed costs? How much are we expecting your claims cost to be? How much is the total pharmacy on a 1 year and a 3 year? You will have all that information. We're not developing a budget for a future plan year. We're just itemizing fees for each of these categories.
I think that's what you're asking for though, right?
Well, I guess in a way, I'm asking for something that's a little bit more because I'm not on the side where I don't know how many claims we have. I don't know. I mean, I haven't been on that side of it for X number of years, for any years, any days. So, exactly, right? So it's hard to know like what all fits into all of these little buckets and to do an adequate comparison. I mean, again, we're trying to be good stewards of taxpayer dollars. We're trying to, keep our employees happy with the services that they're getting, but when we don't really understand exactly what all of that is, it's kind of tough to feel like we're doing a good job making.
I think that what we can commit to is on the everything that you saw today, you will see a number on a sheet of paper for that. And if you have a question about how does that number equate to our overall benefit program, we can speak to that.
Okay.
Clarification on something, on the repricing, and maybe this will help. The repricing that you did on the medical and the pharmacy claims that were.
We did not reprice. We took the.
Whatever you analyze that they repriced, my fault, I misspoke. You stated that they were very similar.
You're going to see that.
Is it also similar to what we're currently paid? Yes, so that's something to note. So
Similar to one another as well.
Yeah, I think that kind of might have just answered her question.
Yeah, so I think we're all saying the same thing a little differently.
Yeah.
You will see line items to those numbers, and you will see how they all compare to a total value together.
Okay.
Yeah.
In your unredacted executive summary.
Yes. Yes.
What you're saying now is in the repricing, all three of them are comparable.
They're within percentage points of one another, yes. So we'll show you the actual
Comes down-
number, but they are.
The other portion is the ASO fee.
So, but what we can do is quickly add to this a summary of ASO so that you see them together, right? I think that's what you're, that's good. Is saying this is the ASO. These are the fixed costs by this one. This was the projected claims. This was the projected pharmacy.
And even if it's like, how long are the rate guarantees? I mean,
Yeah.
that's not a trade secret.
Right, exactly.
That's a proposal to us.
Yeah.
This one gave a 3-year rate guarantee. This one gave a 5-year.
Yeah. No, that's in the unredacted information, 100%.
Okay.
Yeah.
And I just want to set the committee's expectations. So I just don't want to have it to where you've got grids with lots of numbers. They don't know what those numbers are, that they're not having to do the math, that they need the guidance of what that means in the end. And I think that's what you're saying. That's the concern. So the redacted versions are trying to protect this information and not share it, but still get, okay, what does this mean as part of the evaluation? Because you're gonna have to go through all that criteria. And it's just not a numbers game. There's going to be a qualification part of that. It's not black and white. This is a higher number, this is a lower number. There's going to be some gradation there. So,
And I think having that summary would help us weigh out with, okay, this is what we may potentially be paying, but how are we going to be spending it? Do we have can we play with the funds? Can we apply them somewhere? And I think without the full picture, it's hard for us to be good stewards. And so I think that executive summary is better.
That's the piece that would be very challenging for us to as well. Like we can show you comparatively ASO, claims projection, all of that. What makes it harder to evaluate for any of us is the dollars that are being given for those other programs. We can line item out what has been offered to you in each of those in that same summary.
Maybe it would also help for some of the members to understand the point differences of how much is being assigned to cost, how much is being assigned to, but obviously they need some explanation.
10%.
Yeah, but it seems like everybody's fixating on.
Did they give exhibits too?
Yeah.
So can everybody look in the back?
Actually, I don't think
The exhibits were not, okay.
it was an art exhibit. The scoring exhibit.
Oh, here, yeah, there you go.
Yeah, let me go ahead and just remind everybody what the criteria was that was set.
We have a printout of it that we could share. If
I have it right.
Okay.
So I'm reading directly from the RFP. Your award criteria starts with a 65-point value on your proposer's understanding of scope, the objectives, the technical approach, and the work plan presented. In that, when you look at it, it includes your ASO questionnaire and responses, any attachments related, your PBM questionnaire and attachments related, your concierge questionnaire, wellness questionnaire, EAP and behavioral questionnaire. So that's all part of that 65 points. Then your next level points is 15 points for the quality of the proposed system and its ability to achieve the goals and objectives. So that's your reporting and integration questionnaire. Those attachments, your implementation plan that was presented. So the next after that is another 15 points for your pricing and your discounts. That's your ASO pricing breakdown. The sheet that is in each of the proposals, and then along with what they've given you as some of the analysis. Your medical claims repricing questionnaire, your network discounts for hospital, and your pharmacy summaries and pricing tables. 15 points for your price proposal and discounts. And then lastly, you have 5 points for the organization's qualifications and experience. That's that general information questionnaire and the qualifications questionnaire stuff that's in there. So that's how your points are broken down. So just make sure you're taking that into consideration in your evaluation. These are buckets that you're evaluating for that total point value in each of those buckets.
So in other words, fixating on that cost isn't the majority of the points that we're going to be assigning.
And that's in section 2.1 of the RFP. So if you're looking through the RFP document, there's a table in there that breaks that down so you know where each questionnaire falls in that evaluation criteria.
Thank you. And for the committee, that's also broken down under sample sheets that I gave you to make it easier for you to see where you need to work those points. Any other questions for the consultants while they're here today?
That's tomorrow.
I can hardly wait. Just to confirm, I'm going to go ahead and close out this public meeting for today. You guys are going to take some time to do some additional review and analysis. We will be back here tomorrow afternoon at 1 p.m. for a continuation of the evaluation committee meeting and possible scoring tomorrow afternoon. And I really appreciate everybody's time. I know this is a lot of work for everybody, but we do appreciate you guys participating in the process. Thank you and have a great afternoon.
Thank you.
Probably every 10 years.
Okay.
But I know what I'm doing.
Oh, good.